Let's focus now on therapy-related AML with core binding factor translocations. The data shown on this slide is from MD Anderson Cancer Center. Patients with therapy-related AML with an 821 translocation had a worse outcome than patients with de novo AML with the same translocation. You can see there was a higher relapse rate as well in this population. On the other hand, patients with inversion 16 also had a worse prognosis if they had therapy-related AML as opposed to de novo. However, there was no significant difference in the rate of relapse, suggesting that part of the impact that therapy-related AML has in patients with inversion 16 may be due to a patient's inability to tolerate curative intensive therapy because of advanced stage, which was more common in the therapy-related AML patients, or because of prior exposure to chemotherapy. We also know that mutations in p53 are more commonly identified in patients with therapy-related AML than in those with de novo AML. I'm going to now focus on the results of a very important analysis of patients with secondary and treatment-related AML. Patients that were involved in this correlative analysis were treated on a clinical trial with either 7+3 or with an investigational drug, amonifide and cytarabine. Patients in this clinical trial had to have proven myelodysplastic syndrome by bone marrow biopsy or exposure to leukemogenic agents prior to AML and prior to going on the clinical trial. So they were clinically well-defined patients with secondary and therapy-related AML. Mutational analysis was performed in this patient cohort. What was identified is that mutations in genes responsible for chromatin modifications and genes that produce spliceosome enzymes were more commonly identified in those patients with clinically defined secondary AML than in a cohort of patients treated at the Dana-Farber Cancer Institute who apparently had de novo AML. The investigators then identified 3 separate genetic subtypes in these patients, and these patients had either secondary AML or de novo AML. And they identified a secondary type AML genotype, as you can see often with spliceosome and chromatin modifier mutations, as well as mutations in STAG2, a component of the cohesin complex. The second group of patients had p53 mutation, and the third were considered the de novo or pan-AML genotype. The CR rates among patients over the age of 60 with clinically defined de novo AML versus secondary AML are shown here in this slide. Patients with clinically defined de novo AML over 60 who had a secondary type AML by genotype had a worse or lower chance of achieving a complete remission compared to patients with clinically defined de novo AML and without a secondary type genotype or p53 genotype. And in fact, the patients with clinically defined de novo AML with the secondary type genotype had the same rate of remission as those with clinically defined secondary AML patients treated on the clinical trial. In patients with therapy-related AML, patients had a relative chemotherapy resistance. And so in this patient population, clinically defined patients with tAML were again divided into those with the de novo AML genotype, a secondary type AML genotype, and the p53 mutated. Now, the complete remission rate in these 3 genetically defined groups of patients with clinically defined tAML was nearly identical. However, you could see on the right-hand side of the slide that patients with tAML and a secondary type mutational pattern or p53 mutation were more likely to require 2 cycles of induction chemotherapy to achieve that remission, suggesting a relative chemotherapy resistance. And finally, the event-free survival of patients with clinically defined de novo AML over the age of 60 was superior if they did not have the secondary type genotype or the p53 mutated genotype. The World Health Organization has recognized the importance of secondary AML and therapy-related AML in the classification. Therapy-related AML is a second major category in patients in the AML classification by WHO. Patients with an antecedent hematologic neoplasm, such as MDS or MDS/myeloproliferative neoplasm, are now included in a broader category known as myelodysplasia-related changes. AML-MRC includes those forms of AML that occur in patients with 20% or more bone marrow or blood leukemic blasts with any of the following criteria: a documented previous history of a myelodysplastic syndrome or MDS-MPN, an MDS-related cytogenetic abnormality even in patients with apparently de novo AML, and then also multilineage dysplasia found in greater than 50% of the progenitors of at least two cell lineages in the absence of nucleophosmin or biallelic CEBP alpha mutation. I have shown throughout this presentation the importance of an antecedent hematologic disorder and how cytogenetic abnormalities and even now mutational abnormalities are important in determining prognosis in patients with acute myeloid leukemia. But let's focus now on multilineage dysplasia. This is often difficult to determine since at the time of diagnosis, if a patient has predominantly blast cells, there may be few hematopoietic progenitors available for assessment of dysplasia. Furthermore, we also know that there can be some subjectivity in determining dysplasia among hematopathologists. But regardless of these two issues, let's look at the data supporting multilineage dysplasia as a risk factor in patients with acute myeloid leukemia. When the WHO first suggested that multilineage dysplasia be used as a criteria for myelodysplasia-related changes, the German AML study group analyzed data from patients treated with intensive chemotherapy to look at the impact of multilineage dysplasia on prognosis. First, they noted that the event-free survival and overall survival of patients with AML with and without multilineage dysplasia treated with intensive chemotherapy was virtually identical. Also, the survival following intensive chemotherapy based solely on the presence of multilineage dysplasia as a criteria for myelodysplasia-related changes was similar to patients who had AML that was not otherwise specified. In fact, in patients with AML with myelodysplasia-related changes, those who had MRC solely determined by multilineage dysplasia had a superior event-free and overall survival compared to those patients who had either a history of myelodysplastic syndrome or an MDS-type cytogenetic abnormality. And in fact, it has been shown that the genotype is more important than multilineage dysplasia in the setting of nucleophosmin mutation and also biallelic CEBP alpha mutation, explaining why those genotypes have now been given as an exclusion for diagnosis of myelodysplasia-related changes based on dysplasia alone. So in summary, I think it is clear that the outcomes of our patients with secondary and therapy-related AML following standard intensive cytotoxic chemotherapy remains poor, especially compared with patients who apparently have de novo AML. This is partly due to the biology of the disease, as we can see in the mutational analysis and cytogenetic data that I've presented. But also keep in mind it's related to the biologic features of the patients themselves. Patients with secondary AML and therapy-related AML tend to be older. Also, they may not be as fit since they've been exposed to prior chemotherapy. And finally, there is a competing risk of mortality due to the primary neoplasm. Regardless of these issues, it is clear that novel therapeutic approaches should be strongly considered for patients with secondary and therapy-related AML.